morning, welcome again. The first part of my talk is about neurovascular bundle preservation, its anatomy, roots, and troubleshooting. First of all, what I believe is to do a good nerve sparing, we have to know the prostatic anatomy and its fascias. So, levatorani fascia, the terminology is different. Sometimes they use endopelvic fascia, it's the same thing. It has two layers. The first layer is visceral endopelvic fascia. The second one is parietal endopelvic fascia. When you do a high degree of nerve sparing, when you incise it, so you have to be, this is visceral layer and this is parietal layer. If you do a high degree nerve sparing, this part should stay inside the patient. If you shouldn't see the levatorani muscles. If you don't want to do a nerve sparing, you should go directly from levatorani muscles and you should see barely levatorani muscles. So you should decide first where you are going to make the first incision. If you are going to do a high degree nerve sparing, you should stay closer on prostate side. That's the first anatomic important point. The other thing is periprostatic fascia. It's prostatic fascia, it's the same terminology. The prostate capsule is called pseudocapsule. Some authors, they don't believe that prostate has a real capsule. They say that it's only a condensation of fibromuscular stroma. So it's the same. I will use the terminology prostate capsule. Unfortunately, these layers are not like an onion rings. We don't see sometimes separately different layers. I think that's the main problem. So if you look at carefully here, these are from 5 different patients, whole mount sections. They stain prostatic fascia blue and prostate capsule red. If you look at A, there is no prostatic fascia, there is only capsule. If you look at E, a thick prostatic fascia, but you don't see any capsule. In B, prostatic fascia fused to capsule. In C, prostatic capsule is seen, not prostatic fascia. So this may change from one patient to another one. So it means that we can't do the same nerve sparing operation in all of our patients. We have to look periprostatic fascia, but it may not be easy to find it. Sometimes it's fused. We have to keep in mind these anatomic variations. What type of nerve sparing we are doing? The first one is interfacial dissection. This is capsule, prostate capsule. This is prostatic fascia. This is endopelvic fascia. If you go between this plane, prostatic fascia and endopelvic fascia, this is interfacial dissection. So it's oncologically safer approach. You don't preserve 100% of all nerves, around 75%, but it's a safer approach. The second one is intrafascial dissection. So to do an intrafascial dissection, it should be only in low-risk patients. You strictly follow the prostate capsule. It's very easy. What I believe, intrafascial dissection is more easy than interfacial because you see the capsule, it's shiny, bright, and you can follow your roots. So what's the route? We can do either retrograde or antegrade. How many of you are doing retrograde nerve sparing? Could you please raise your hands? Antegrade? Mostly antegrade. Let's discuss a little bit retrograde also. What we call incremental nerve sparing. If you have a low risk of extraprostatic extension, you can do a closer dissection. If you have a high risk, you should do a wider dissection. This approach is named during the last year's incremental nerve sparing. Is it possible to do an incremental nerve sparing at the same patient? This is one of my patients' videos. Yes, it's possible. If you look at to the right side of the prostate, this is intrafascial dissection at the same patient. If you look at left side, there is a little tiny periprostatic fascia stayed on patient's side. You can do one side intrafascial and the other side interfacial. You can do this the same patient. You can look the MRI, biopsy results. If you are sure that there is no tumor on one side, you can do intrafascial dissection on one side, and you can do interfacial on the other side just to be oncological safe side. So, how we will do incremental nerve sparing? We can do in two ways. The key anatomic landmark, if you look at Ashtavari, he described to get veins, and look at veins. If you dissect below the veins, this is the highest degree of nerve sparing. If you dissect on the veins, this is the second degree, it's around 75% you protect the nerves. If you below the veins, 95%. If you dissect distant from the veins, a little bit nerve sparing you can do. If you go above extrafacial dissection, far away from. So, is it possible to see the veins on patients? Yes. You will see here, this is a retrograde, one of my cases. So these are the veins. You have to be careful. Veins always tend to bleed. If you have bleeding, you can rise the phenomenon peritoneum. I don't think that it matters a lot. You can rise at 16 or 17, you can have a bloodless clear field. So after that, push it gently. And all vascular veins stay patients inside. This is the neurovascular bundle. This is the highest degree if you look at Ashtavari. And after that, with Patel, he described his retrograde technique as getting key landmark, the artery. He calls it landmark artery. So he started from 5, just to say different from each other. One of them started from 1, the other one started from 5. It's hard to understand, but the 5 starts from blunt dissection below the arteries, the 4 sharp dissection at the level of arteries, and it goes on. 1 is extrafacial dissection, it's just numbering reverse. So is it easy to find landmark artery in every case? No, it's not. Sometimes you may not be able to see it. You can see on only 75% of cases. It's not recognizable. This is landmark artery. You will see here. This technique may not be easy to find it during the learning curve. How we will do a good retrograde nerve sparing? What are the key points? What I believe is posterior dissection is the most important part of retrograde nerve sparing. If you do a good posterior dissection, you will make it. If you don't do a good posterior dissection, you are not going to be able to do a retrograde nerve sparing. If you are using SI, first I start for 30 degree down, then I shift to 0 degree. If you are using XI, you can shift 30 degree down to 30 degree up, but you have to dissect all these planes patiently and very clearly. If you do a good posterior dissection, the retrograde nerve sparing will be much more easier. So this is the right side of the same patient. With retrograde nerve sparing, what I believe, there is always less traction if you compare to antegrade nerve sparing. And you do the traction, just its longitudinal axis, the neurovascular bundle side, and you don't do too much traction. You see, you can do the traction like this, not the reverse side. The other main advantage of retrograde nerve sparing is prostate pedicles. You see there's less traction. This is pedicle. You can decide to put where the hemorrhoid clip. If you are concerned having a surgical margin positivity on pedicle of the prostate, okay, you can keep it, put it a little bit far away. This is landmark artery, it's well protected. The same patient, this is one of my patients, the same patient left side, it's easy, you see the traction is not this way, it's along the neurovascular bundle course. So it creates, if you have neuropraxia because of traction, what is my experience? It will take 1 or 2 years to gain erectile function again. Neuropraxia is very important, it doesn't come easy. So you can put wet clip if you want to stay close and leave a big posterolateral side tissue, you can put the wet clip where you want. The other thing is periprostatic nerve distribution. It's in most of the patients, the periprostatic nerves, they are not in posterolateral side of the prostate. Some of them are going anterior side of the prostate. At the apex, 40%. At the base, 20%. You look, they come to the anterior side. So if we do an antegrade, high degree nerve sparing, is it going to improve erectile function and continence? Yes. If you do a high degree wave of Aphrodite, it will help. But this should be performed only in low risk patients. If you want to do a highest degree nerve sparing. In this patient, he had a very low risk, but he wanted to undergo surgery, so he was a young patient with a big prostate. So you start from the base and you clip the pedicles, then slowly cut and push, and you can preserve most of the nerves, as you will see here. Slowly.
The cases where the nerves come off that well, you're sort of like, well, he better be potent because it can't get any better.
Okay. So if you see, the nerves are protected until here. So each part of the nerves are protected. So I will ask a question. You protected the nerves, but there is always bleeding from nerves when you remove the prostate. What do you do in this case? How many of you put suture? We have time. But the suture may harm the neurovascular bundles, right? But even very small. How many of you put a cauterize? Tamale drops the cautery to 10. He says that that's only 10. A little bit buzz. How many of you use cauterize? One gentleman. Thank you so much. So I will offer you a different approach. I am using this nearly 2 years. So this is a Vivostat. It's produced in Denmark. They took patients all blood, 150 ml, and it's a machine. Just before the beginning of the procedure, they make it an autolog fibrin glue. It's patient's all blood, no allergic reaction, no extra cost. So we apply this fibrin to neurovascular bundle areas. It stops all of the venous bleedings. So I don't use any suture, I don't use any cautery, except the bleeding is not coming from the bladder side, pedicle side. Okay, thanks so much.
You have one more